Hello, everyone. If we could just be seated and settle in, I'm going to get us going in just a moment. Thank you. All right, we're almost at the end of the day. My name is Tio Quay. I'm Assistant Director Research with UBC Health, and I have the absolute pleasure of being able to introduce our closing plenary. So Dr. Kiran is a family physician and a renowned primary care researcher whose work is transforming how we think about health system change in Canada. Dr. Kiran holds the Fidani Chair of Improvement and Innovation at the University of Toronto and practices at St. Michael's Hospital Academic Family Health Team, where she's also a scientist at the MAP Center for Urban Health Solutions. Her research has helped us understand how system reforms impact care, especially for the most vulnerable, and she's developed innovative approaches to reduce disparities, support clinicians, and engage patients in shaping services. In 2022, she launched OurCare, a national initiative that engaged nearly 10,000 people across the country to co-design a stronger, more equitable primary care system. Today, she'll share what they heard and invite us to imagine what it would take to truly align our primary care system with the public's vision. Join me in welcoming Dr. Kiran.
Thanks so much for having me. I hope everyone can hear me all right. I'm so sorry that I can't be there in person. I'm zooming in from Toronto, the traditional lands of the Huron-Wendat, the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and many other nations. And I'm delighted to join you virtually. As Tio mentioned, I'm a family doctor. I've also been doing research for many years now, 15 years, family doctor for 20. And, during that time, I've actually been involved in a lot of conversations about healthcare reform. And one thing that I noticed is usually the people around the table, they were often people like me. They would be maybe clinicians or researchers, policymakers, maybe health system leaders, policy experts, but often the very people that should be at the table were actually missing. And that's, of course, patients and the public. That's why we started OurCare. We really wanted to give a voice to the very people who the system should be designed around. Over 16 months, we heard from nearly 10,000 people across the country who collectively spent about 10,000 hours with us, not just about their experiences of care, but what it is that they wanted to see in a better system. And our hope with engaging these folks and bringing out their priorities was first that we would have like a clear direction forward, a North Star that could guide us in terms of where it is that we needed to go. I also realized from experience of engaging patients in the public in the past that often when you do that, it helps shine a new perspective and can often actually be surprising in terms of what the priorities are relative to what you might have thought they were. I think the other thing that I hoped is that by engaging patients in the public and bringing a patient and public-centered vision forward was that many of the interest groups that often are around the healthcare table could see past their silos and come together with that common vision and North Star to actually move something forward. And so today, what I want to do is tell you more about what it is that we did with OurCare, and then also what we heard from people. We'll also then reflect on where it is that we are at now in relation to where it is that we want to go and how we might be able to go there. And then I'm really looking forward to getting your questions and engaging in some dialogue around all of this. And if you've noticed that my eyes are moving, it's just so because I'm using this new clicker technology that I'm getting used to. So bear with me. So I just wanted to say that, as I tell you about OurCare, I really want to acknowledge up front that we engaged a lot of partners throughout this work. So this wasn't just me doing this work. We had 2 national advisory committees and actually 5 provincial advisory committees, one in each of the 5 provinces that we were more deeply engaged in. So you can see we had more than 200 individuals representing more than 60 organizations that did this work alongside us and helped to shape the initiative. I'm also really thankful to our funders, Staples Canada, Max Bell Foundation, and Health Canada, who helped to make all of this possible. I should also say that this work was done in partnership with my colleague, Dr. Peter McLeod. He's actually not a physician. He leads an organization called Mass LBP, which is actually designed to support citizen engagement. They believe strongly in this view that if you take ordinary people and you bring them together with the right facilitation and education, they're actually able to solve complex problems and help us to move forward in an aligned and consensus-based way. So I should mention that I do have a number of supports here, but I don't think any of them pose a conflict for today's presentation. So to start, the first phase of OurCare was a national survey. We launched the survey in the fall of 2022, and we heard from more than 9,000 people across the country about their experiences with care, whether they had a family doctor, a nurse practitioner, whether they were able to get care in a timely way. But also, we gave them a lot of kind of options for, okay, what if we did things differently? How willing would you be to kind of access care in this kind of scenario? So, for example, how willing would you be to see a nurse practitioner instead of a family doctor? And so I think through the OurCare survey, we really got a snapshot of where we were with primary care and also what it was that people thought was important. And you can find all of the results of our survey online at data.ourcare.ca. But I think what really made OurCare unique wasn't the survey, but rather the real dialogues that we had with people. And that started with our second phase, which were these 5 provincial priority panels. These were really citizen reference panels that we conducted in each of 5 provinces across the country. That included Ontario, Quebec, Nova Scotia, Manitoba, and of course, British Columbia. In each case, we brought together people from around the province who were strangers. They had never actually met each other before. And they were, though, randomly selected. And so what you can see here is I've included this snapshot of kind of who it is that we included in the BC Roundtable. The people in BC, they were randomly selected from a group of volunteers. And then what I mean by that is, a lot of people raised their hand in the survey or through other recruitment methods and said, yeah, we want to spend 30 hours together learning about primary care and deliberating about what its future should be. So that's pretty remarkable. And then from those people, we randomly selected so that they roughly represented the demographics of the population overrepresenting for equity deserving groups. And you kind of can see the 8 factors that we took into account in British Columbia. And you can see here, like in a snapshot, where it is that these people lived. And in essence, we were really just trying to bring British Columbians together in a room. So, if you had to take a snapshot of British Columbia, it would be there in the room. Now, I realized and I should say that, what happened during these sessions was the first 2 sessions for most of the provinces, and in Ontario it was 3, but in most other provinces, we had 30 hours, and they started with 2 virtual Saturdays together, and then they went on to 3 in-person days. And it started off with a lot of learning. So we had so much we had so many wonderful speakers who actually volunteered their time for this initiative and provided plenary talks to people about things like access, equity, teams, about health systems in other parts of the world, and other topics that people were specifically interested in. But as the days went on, there was more and more time actually spent in small groups where people were able to deliberate with each other. And that's where really the hard work began, because as you can imagine, these were people who didn't know each other, and they sat together in groups, thinking through what were the values that they really wanted this to underlie the system. What were the issues that were most important? What were the things that they wanted to really prioritize in terms of improvement, and what recommendations finally would they have for the healthcare system? And this is the panel in British Columbia. They gathered together in June of 2023 in person. You can see they're quite a diverse crowd. And at the end of this time together, they actually had the opportunity to present their findings to really senior stakeholders. We had more than 20, I think, in the room in British Columbia, and it was really felt powerful for people to actually hear directly from the mouths of ordinary people what it is that they wanted to see done differently. And then following that presentation, they actually came together virtually to edit a document and then finally publish out a final report that's on our website that summarizes all of their recommendations in their own words. I showed you that photo of British Columbia, but we actually did this process 5 times. So in February, we were in Ontario. In May, we were in Quebec. I mentioned in June in British Columbia, and then in July in Nova Scotia, and then finally in October, we were in Manitoba. And each time the process was similar, and the panel put together its own recommendations, and we published a report that was written by the panel that you can find on our website. And in all the cases, we really tried hard to have these spaces, these conversations be inclusive. But we knew that with both the first and the second phase of OurCare, we were probably leaving out some important voices. And I know health equity is an important actually topic at the conference over the last couple of days. And it's with this lens of health equity that we really launched our third phase, the 10 community roundtables. So these roundtables were 1 day in length, and they were done in partnership with community organizations that had established relationships with marginalized populations. You can see from the slide that we worked with different kinds of communities, Indigenous communities, Black communities, many different kinds of newcomer communities, the LGBTQ plus population, and the community of people with disabilities. For some of these we really tried hard to make them accessible. And so, for example, many of these roundtables were actually simultaneously translated in 3 to 5 languages, which was quite remarkable to see. They spent the day together and they reflected on their own experiences. They shared what was going well, what was not going well, what needed to be improved. They reflected on the priority panel recommendations and how their own recommendations might align with those, but also the ideas that they had that were different. And at the end of the roundtables, we have a report that kind of really summarizes what it is that we heard from these different groups. So all in all, we actually published 17 reports, all of which are on our website at ourcare.ca. And the final report actually came out in February of 2024, and it really summarized what it is that we heard through all of our consultations. Because what was really remarkable was that, in each dialogue, despite the fact that they were strangers coming together at a time of pretty intense polarization in our society, despite all of that, there was so much that they agreed on. And then what was also remarkable is that when we looked across all of the engagements, there were so many commonalities with what it is that people said. And at the heart of what people told us was that they believed strongly that every person in Canada deserved access to high quality primary care, regardless of their background or where it is that they live. So over the next bit, I'm going to tell you more about what it is that they told us and wanted to see. But before I do that, I'd like to share a video with you, one where you can hear directly from some of the people that were involved in the process. You'll hear why it is that they volunteered their time, but also what they learned from the experience.
I volunteered to be a part of our Care panel because of my own health issues. I struggled between having a doctor, losing a doctor, and then having a doctor and losing a doctor, and being resorted to walk-in clinic, which has not been able to help me in my own healthcare needs.
And I wanted to be able to provide our voice to the people who make policies in order to try and make it a better experience for other people going forward.
And knowing that my generation is going to be inheriting this very important system, I feel like it's my duty as a citizen to do my best to build the system and improve it so that it can be sustainable for the long term.
Ce que je trouvais qu'on a en commun, c'est chacune de ces personnes-là qui sont ici présentes, de ces collègues, ils sont ici pour le même but de se faire entendre et d'apporter d'amélioration.
I'm not as alone as I maybe thought I was. Everybody, even though you have different backgrounds or different histories or different needs, all really at the end of the day wants the same thing, which is a healthcare system that works for everybody.
Whoa, okay, I'm not the only one, and to realize that a lot of people have the same goals in mind in regards to healthcare and how they want to improve healthcare.
I felt like I was a pretty good navigator of our healthcare system and found out there's so much I don't know. And so if I don't know as someone who thinks I know quite a bit and has used it a lot, how much do other people not know?
To bring 36 people together with varied backgrounds from various parts of the province to get together and literally in less than 2 full days of working, we're developing strong, actionable recommendations.
Because I know personally I'll take, whatever I've learned over the last 4 days back to my own, town and area and try and continue the work that I've come to realize as being important here in the group.
I have learned way more about how the healthcare system in this province works than I ever thought I could learn this quickly. I've also learned, though, that the answers to the current crisis are probably in the room with us. We just need to get the right people to listen.
You can hear there this patient's stories about why it is that they volunteered for this. For the most part, they were really motivated to make the world, the Canada, their community a better place. And they were also really grateful for the learnings and their journey through the process. They wanted everyone to have that kind of education and opportunity. We heard that again and again, and they were grateful to be connected with other people, to hear that there were people who were very motivated in the system, like you guys in the room, to make things better. And they were, of course, grateful to know that what they were going through wasn't something that they themselves were going through. And I think that the process itself also helped everybody kind of see how, as a group, when we come together, that can be really powerful and that we can accomplish something that, we might not be able to do on our own. So, we heard a lot from them, and I can't do justice to telling you all the nuances of what they said. But what I do want to convey is the high-level pieces that we heard and something that we came up with to kind of really distill what it is that the panelists and the folks from the community roundtables and people from the survey told us. And that's through something we call the OurCare standard. It's 6 simple statements that basically summarize what every person in Canada should be able to expect from the primary care system. And they are a summary, really, of what it is that we heard through all of our engagements. And I'll go through each of the statements sort of one by one. Some of them I think are more straightforward, and others I think take a little bit more explanation. The first is that every person should have access to primary care. That means a clinician working in a team with other health professionals, and it should be publicly funded. People were really supportive about teams. They recognize it as a way for them to be able to get more comprehensive services, for a way for providers not to have burnout, but also as really the only way in a crisis of a health human resource crisis for us to be able to offer primary care to everyone. They wanted their primary care to be both timely and ongoing. They talked about virtual care being part of that, but virtual care being integrated with in-person care and being incorporated in a way that actually enhances equity. So, for example, prioritizing virtual care for people living in rural or remote areas as a way to enhance access. They also talked about how care, they didn't want it to just be 9 to 5, Monday to Friday, but ensure that there were after hours and weekend options as well. Standard 3 relates to the concept of people saying to us, that they wanted a wellness-oriented system, not a sickness-oriented system. And they wanted to see primary care connected with community and social services as a way to address social determinants of health and promote overall well-being. Standard 4 relates to what we heard again and again as a really common frustration. Why is it that people don't have access to their own medical record? And so Standard 4 asserts that this should be the case and that people should be able to share that record with their loved ones, with their caregivers, and with their clinicians. Standard 5 asserts that everyone receives culturally safe care that meets their needs from clinicians that represent the diversity of the communities they serve. This standard really reflects that we heard over and over, unfortunately, about real instances of personal racism and discrimination that people experienced in the healthcare system, and that's not okay, and we need to correct that. We also heard that sometimes people would go to their primary care clinician's office and, that clinician might say that the thing that they needed care for wasn't really in their scope. So let's say they needed help with addictions or gender affirming care. Sometimes they were turned away. And that's not really okay. So that care really should meet all the needs of people and also be accessible from a language perspective, from a disability perspective. And the last part of the standard reflects that what we heard was that, for care to be culturally safe, an important step is for the providers themselves to reflect the community that they serve. Because in instances where that occurred, people did feel safer and there were fewer incidences of racism and discrimination. Standard 6 is that everyone receive care from a primary care system that is accountable to the communities it serves. And I think about that in a few different ways. So first, we heard over and over that people really wanted transparency in the system. They wanted to know how much money was being spent, what were we getting for those investments, how was the primary care system performing? They also wanted to be involved in decisions about how care was set up. So that could be even like choosing what metrics we use to measure primary care performance, to supporting, what services should be delivered in a region. So being involved in decision-making at different levels of the system. And then the third element of this standard to me also relates to patient education and empowerment. So enabling people to know how to navigate the system and providing them with the education to be able to manage their own health and know what to do if they're not, for example, getting the services that they are entitled to. So these 6 standards really summarize all that we heard, and I think are a North Star for where it is that we want to go. And when we published these in February 2024, in the months leading toward the publication and the weeks leading to the publication and in the months afterwards, we did a lot of work meeting with senior stakeholders in different governments with the goal that governments across Canada adopt the OurCare standard as the way forward, as the North Star. And what was absolutely been unbelievable is that last week this actually happened in Ontario. So I don't know how many of you are keeping up with the news in Ontario, but a very exciting announcement last week that Ontario is the first jurisdiction that's going to be introducing, or they have introduced, a Primary Care Act into the legislature. And if passed, they would be the first jurisdiction in the country that has such an act outlining what it is that people should be able to expect from the primary care system. And the act actually lays out 6 objectives for primary care in the healthcare system and asserts that primary care should be the foundation of the system. And what's remarkable is that these 6 objectives in this act that's now in the legislature being debated all line up with the OurCare standard very clearly. So this is the work of many people to get us here, including Dr. Jane Philpott, of course, really who's leading the primary care action team in the province of Ontario. And she's been a really big supporter of OurCare. And I think OurCare really inspired the objectives in the Act And you can see it's mirroring right here on the slide. So really unbelievable. It's still something that, I'm still processing myself, because I have to say, in research, you never expect that the work you do is going to be able to land in this way. And I'm excited about what this means for other parts of the country. I think it's an incredible win for the people of Ontario that their voices were heard and reflected in this way. I know that this symposium, this conference, really is about bridging research and action. And so I wanted to take a moment here to just even reflect on how is it that we got to this place where the work that we did over a few years culminated in this legislation that we think will likely be passed, given that it's a majority Conservative government and they're early in their mandate right now. So, a few things. I think that this work really has resonated with people because it's reflected what we heard from patients and the public. And it's hard to argue with what it is that people say that they are experiencing and what it is that they want. This is not a doctor lobby group saying, or a nursing lobby group, or some other lobby group saying, yeah, we want X, Y, and Z, and then the system will be better. This is really a people-centered initiative that's amplifying the voices. And I think what really also supported this to come to the place it is that we were able to put together a really broad coalition. As you saw, many, many different organizations were part of this process, and we worked hard to get their support all along the way, including when we released the final report and for the OurCare standard. I think people also were, found that the process was credible because we had a rigorous process. But at the same time, I think we published all 17 reports, but at the same time, we simplified our findings to these 6 OurCare standards, something really digestible for policymakers. And I think that also helped with the uptake. Throughout our project, we had strong and consistent media engagement, which was wonderful, and I think really pushed the public, the public perception about these issues, and then the politicians' perceptions about these issues and the importance. As I mentioned, we also did a lot of direct engagement with policymakers. We even hired a government relations firm at one point. I'm not sure if that really supported us to really move it forward, or this would have happened anyway, because I will say one of the other pieces was this happened in a very quick way, much quicker than normally research does. We actually didn't peer review, publish the OurCare standard. It's something that's in a report. And I was really pushed on the timeline by my partner, Peter McLeod, who's not a doctor, not a researcher, but really has a small business that does citizen engagement, and needed to do this work fast so that they can move on to their next project. And who also recognized that the time was now, that there was a potential window, and that if we dragged on or started a bit later, that window might close. And he was right, there was a window. And some of that window, I will say, was completely unpredictable. None of us could have predicted that in the fall, the Premier of Ontario, a Conservative, would have appointed a former Liberal cabinet minister, Jane Philpott, as the primary care action table lead, and then have primary care as the priority signature piece. So lots of things that I think contributed to actually moving that research into policy in Ontario. But now we've got hopefully the legislation that'll be passed. We still know that there is a lot of work ahead of us. We've got a clear vision, and I think we've got some action steps. But I do think we have to reflect a bit on where we are now and how is it that we can get to the North Star that is that patients articulated for us. So I will say that we do need more data to understand where exactly we are right now, because as I mentioned, the survey we did was back in fall of 2022, and I'm excited that we're just in the last couple of weeks out in the field with a new OurCare survey. This one, the goal is to measure how people's experiences of care measure up to the OurCare standard. And you can find it on our website at ourcare.ca. You can go to ourcare.ca or ourcare.ca/survey. And we would love your help with spreading the word to patients, families, community members across your province and elsewhere in Canada to take the survey to let us know what their experiences are like. But what we did find in fall of 2022, of course, was that more than 1 in 5 people across Canada reported not having a family doctor or nurse practitioner they could see regularly for care, and translated to the population of Canada, that was more than 6.5 million adults. What was really striking, though, was the incredible regional variation between provinces. And we'll talk about that in a moment. I will say that even those who had a family doctor, though, were still also struggling to access care, whether that was care when their physician was away, or care after hours, or care for something that was urgent. Often that was not available to people, even if they did have a family doctor or nurse practitioner. We saw a lot of support for team-based care, yet at the same time, we saw that, it was less than 15% of people who said that there was a social worker or a dietitian or a pharmacist that was part of their family doctor or nurse practitioner's office. Now, I mentioned the regional variation. I will say this has been really interesting. We published on this last year where we, after we controlled for a number of different factors, the factors that really stood out in terms of what influenced whether you have a family doctor or not were really, age and what province you live in. And when we looked at, whether you could get timely care for an urgent issue, again, what province you live in was actually the strongest determinant of that, with British Columbians actually having, I think, reporting the least good access or the worst same day, next day access for urgent issues. And again, when we looked at team-based care, we can see that the province you lived in, again, was the strongest predictor of whether or not you had access to a team. And so if you lived in Ontario and Quebec, you were much more likely to have access to a team than in British Columbia, the Atlantic region, or the prairies. And so I think this is worth us reflecting on for a moment because, again, as we think about equity across the country, we know that from lots of different research that newcomers and people who are Indigenous, people who are racialized often have access barriers to primary care. But what we also see from our survey is that an even bigger factor is the province you live in and the policy environment that is affecting who does and doesn't have access. Because what we have in our country, unfortunately, is a bunch of haves and have-nots. People who have maybe a family doctor, a nurse practitioner, maybe they work in their own office with a medical office assistant. Maybe they work with an amazing team, so it's like a have plus. But then we have a whole bunch of people who have nothing. And some people are living in a province where just everybody is more likely to have rather than have not. And others are living in a province, where they're much less likely to have versus have not. And that, of course, intersects then with those other sociodemographics in terms of being able to, for people to be able to access care. So I think it's something for us to reflect on in terms of the broader policy environment and the impact that that can have on everybody, and as a result, on relative equity. So I want to take the last few minutes to think through how it is that we can actually move the needle. And I'm going to start by actually sharing some reflections on team-based care specifically. So I'm going to share some reflections from the province of Ontario. This is me back in 2002. I graduated from medical school that year. You can see me right there in the front of the University of Toronto, King's College Circle, looking all happy and excited to go into a family medicine residency. But actually, I was one of few graduates at that time who were choosing family medicine as a specialty. It was decidedly unpopular. And it was, in fact, one of the few times that our medical school went unmatched and not all our family medicine spots got filled. And the landscape there was very different than it is today in Ontario. So at that time, most doctors were working on their own, maybe with a few other doctors in an office, maybe with a medical office assistant, getting paid fee for service. fast forward to 2025. I'm still happy. I'm actually coincidentally wearing the same shirt today. But here I am in my office, and I work in a team-based environment, and I love it. I get paid actually on capitation, so that means I don't have to worry kind of about making sure that all of my work is done in the space of visits. I can think more flexibly than that. And I have so many wonderful team members that I work with, and I know that can provide my patients a level of care that I would never be able to provide them on my own, and that provide me with a lot of joy and work. And I'm not the only person working in that environment. I would say, about 25% of folks in Ontario are getting care from physicians who work in a team that's similar to mine. But I think there's a lot that we can learn from Ontario and our journey in team-based care over the last 20 years. Over that time period, myself and my colleagues in Ontario have done a lot of research trying to unpack what's been that impact of teams on population and population health. And to be honest, it's been a bit mixed. Some of our studies have found, some of the reforms that were put in place didn't have much of an impact. We did have a couple of studies that did show some positive things in relation to, for example, the people who got care from teams being more likely to get recommended diabetes care and less likely to visit the emergency department. But notably, actually, some of the biggest gaps in quality really were between those who were and were not enrolled to a physician. So any kind of differences in quality of care that we saw between different kinds of models was really pretty minuscule compared to the gaps between those who did and didn't have a physician. Importantly, I think some of the most important research was done by my colleague Rick Glaser, who really showed that the distribution of teams in Ontario was not rational. In fact, some of the most high needs areas were the areas that had the lowest number or per capita distribution of teams. So even while we were doing all of this research that found some good things, but also I think was sometimes critical, I did myself, as I say, work in a team environment and recognized the value of it and wanted to see how it is that we could use our resources to best provide the best care possible to our patients and also demonstrate what good looks like. And so for, a number of years, I think almost a decade, I was the director of quality improvement at our family health team. We started to do things like measure patient experience, tried to improve access and cancer screening and equity in cancer screening and opioid prescribing and hepatitis C treatment. And we did. We didn't just try, but we did using quality improvement methods and sometimes published on those. And I will say, reflecting today on this research to action theme, I do think that that is an important contribution as well. It's not just the big R provincial data set based research that might shed light on kind of populations at a big whole or evaluate specific reforms, but I think it's really critical that teams on the ground innovate and demonstrate what's possible, and then hopefully share their stories, whether that be in a peer-reviewed forum or in a different way, ideally in a way with some rigor that others can kind of say, oh yeah, that did happen and we can do it too. But despite all of what I've told you, I do think we need to step back in Ontario and rethink it is where we are, and we actually are at a time where that is happening. I will also reflect that, unlike with the OurCare standard, where we published the report in 2024, and now we've got some legislation being introduced in 2025, my colleagues and I have slowly been doing this work around primary care reforms, evaluating them, trying to make team-based care better over a 20-year period. And it's only now that some of our work is really being paid attention to and changes potentially being made in the system as a result of it. So sometimes patience is needed. But I will say, I know many of you are interested in moving team-based care forward in BC, and I'll just say a few things. One is, as we think about moving teams-based care forward and we think about adding layers of other professionals to physician practices and having them work together in a team, we also have to understand that I think at the basis for a lot of the teams, we do have to have functional physician groups. This means physician groups that are sharing records together and providing cross coverage. Without that, it's really hard to have an effective interprofessional team. I also think it's really critical that we specify objectives. The other thing that I didn't show you a slide on today, but is some unpublished work that we're kind of in the midst of right now, is that we can see from the data that even though teams have extra resources and in theory can actually help us as a clinician to serve more patients, in practice we see the teams in Ontario actually have lower roster sizes than the non-team models. Why is that? I mean, I will say specifically, I think that increasing capacity of the clinician to see more patients was not a specific objective of the family health teams. Instead, we often have add-on or duplicative care that kind of developed within these models. So, instead of me as a physician just seeing a patient with diabetes on my own, now often like maybe the nurse would see the patient first and do some things, and then I might see the patient next, and maybe the patient is getting more care and even better care than they were before. But it's not more people getting care because, in a system with more people getting care, we probably have to transition to a nurse actually taking on the full diabetes visit and me as a physician not needing to be involved unless things are complicated. So we do really have to specify the objectives of teams and I think prioritize what it is that we want to see. And in the current environment, I would argue that is enhancing clinician capacity. We do need to be transparent, measure, and report on key indicators. I'd say when we looked across the province after publishing the OurCare report, there was actually only one province that was routinely reporting on primary care performance, and that was New Brunswick. And so, it's something low-hanging fruit that we need to do better on. We do need some more standardization, understanding that regions also need flexibility, but I will say that the models that developed in Ontario are really all over the map, and they don't really provide a really standard for what it is that patients should or can expect when they go to a primary care clinic. There's just so much variation, and I think some variation makes sense, but I think actually in Ontario we've gone too far with the heterogeneity. And last and most importantly, I would say we have to design for equity. And so if we're not going to roll out teams to everyone all at once, we do need to start where the need is highest and really incentivize teams to care for some of the most complex patients. I will say that our OurCare panel did make some great recommendations on teams. I'm not going to go into all of them, but I would just say in BC in particular, they talked about starting team expansion in areas of greatest need. And they also specifically called out in BC the community health center model as one that they really liked and wanted to see spread. They had some specific wording around that in their report, but in particular, they liked the fact that it was community governed and that it was community based. And so it's a model I think that's doing a lot of good things in BC from their perspective that we could see scaled up. In Ontario and BC, they also, both panels actually talked about this idea of like comparing the primary care system to the public school system. And this is a quote from the Ontario report. It says that, to ensure that every Ontarian has a primary care home, the government should move towards automatic rostering similar to the public school system. Health teams should be mandated to accept any patient from their catchment area, but we still need to maintain an element of patient choice. So they came up with this term, automatic rostering, and reflecting that, it was a way to ensure that everybody had access, and still they wanted patient choice, not to have patients forced to have to be part of a team. But with this kind of model, no longer would you have to, be on a wait list and wait years potentially, or, have to call around to try and get accepted. It would be something that would be equitable and available to everybody. So as I wrap up, I will say I thought to be able to share some of my travels and international experience, but I just think it may be too much for today. But I will just say that, in my next phase of work, I have really been thinking about how can we work differently as family doctors, as primary care clinics, and influence that policy space and also the practice space with some new and innovative thinking. And, I've had the chance over the last year to visit a few countries, Denmark, the Netherlands, and Spain. These countries are different from us, I should say, in many different ways. They have more doctors per capita, they spend more, they're smaller in size than us, they're kind of more socially equitable. But I still think there's a lot we can learn. And I won't go into a lot of detail, but just to say that things are done differently in these countries. For example, the clinics often don't take as big a role in prevention. That's done by other parts of the system. Instead, doctors and clinics there, they really focus on acute care as well as complex care. There's a lot more accountability for access in all of the systems. So for example, in Denmark, this beautiful clinic that you can see here, there's sort of this contractual obligation that GPs have around, being open 8 to 4, Monday to Friday, rostering 1,600 patients for a full-time clinician, being able to see any urgent issues same or next day, having to see non-urgent issues within 5 business days, and participating in after-hours rota. Really minimum specifications, but clear ones that set like a very clear groundwork for what minimum standards there are for access in the country. And in all of these countries, they do a pretty good job of something I call demand management. And so this is the idea of, if we're really looking after a lot of people, how can we ensure that the people that need to be seen the most are the ones that are being seen today versus those that can wait a day, 2 days, or next week, and who really needs to be seen by the doctor or could be seen by another professional. And this is just a snapshot of a practice assistant from the Netherlands, a really interesting group that they've trained there that's able to do this triage. And we can talk more about that if you're interested. They also have really delegated tasks, as I mentioned. I talked about how in Ontario, nurses often are providing duplicative care, not substitutive care. That's not the case in these other countries. In these other countries, nurses are really leading stable chronic condition management. Some of these countries, like the Netherlands in particular, have amazing integrated after-hours care where groups of doctors are working together to serve a whole region. And virtual triage is connected with in-person care. And in-person means not just in the clinic, but also actually going to people's homes. So we're not leaving out the most vulnerable, which is something that I really appreciated in their system design. They also do a lot more to empower patients to look after themselves. There's like a whole website based on GP guidelines that's patient-facing that actually supports people to manage minor illnesses, not send them to a pharmacist for something that honestly actually doesn't need any antibiotics. Many of them have integrated records, and we can talk more about that, but just to say, even if they don't have integrated records, they've got a viewer. In Catalonia, the whole population has been able to access their records through an app since 2009. That's a country with far fewer resources than Canada in 2009. I think we just gotta think about that. And then, I'll just end by saying in Spain, it was really one of those models that is kind of very similar to that public school model. And what I loved about it, it was like really centered on patients and communities. And they did this thing in the clinics where they actually worked with epidemiologists to understand, how is it that the population has changed over time and how should their services change as a result. And they looked at it quantitatively, but then they also did focus groups to understand what was most important to people and used those kinds of focus groups to inform their services. So that was just a bit of a teaser, but if you're interested in more ideas from other countries, I'd just urge you to check out my new podcast. It's called Primary Focus. You can search for it in any of your podcast apps. Just put in Primary Focus. They're my name. And I hope you subscribe. We just actually dropped a great episode yesterday on the Netherlands, and I take you with me. It's kind of like an audio documentary. So as we wrap up, I'll just say a couple of things that, I talked about a lot of change ideas, and I do think that they take money. And so I think we shouldn't pretend that we can innovate and improve the system without some more investment. Canada does spend less on public health care than comparator countries that have more high-performing primary care. And we also, we look at our total health budget, spend a much lower proportion on primary care than OECD comparator countries as well. So we need to grow our pie and of dollars in public health care and spend more of those dollars on primary care. So thinking differently, and I think we can get there with some investment and with some innovation. So I look forward to your questions and discussion. Thanks for having me today.
Thank you so much, Tara. That was an amazing overview of what's going on in the country, and I love those stories at the end. Just sharing a personal anecdote, I lived in Denmark for several years, and when I arrived, almost immediately I had a letter saying, which of these 5 doctors would you like to choose in your area? Not prompted at all. I didn't have to, say anything. They just knew I was there and I had a doctor available. So, it can happen. Big dream, but yeah. Anyway, I'll maybe just share a couple of the questions. I think we have about 10 minutes left. And so if you haven't had a chance, feel free to share your questions in Slido, or you can also share your hopes for primary care reform in BC. We have a few ideas trickling in. And so the most popular question so far is, given limited resources, should we prioritize specific types of care, such as perinatal care, or do we need holistic, comprehensive approaches that may take longer? So Tara, I don't know if you...
A really great question. I think that we should be prioritizing. I think we should be designing a system where everybody gets care. I think if we just continue to try and do Band-Aids or incremental improvements, we will never get to a point where we have better. Because the incremental improvements really means there doesn't need to be a lot of change, and the same thing with Band-Aids. And what happens with the Band-Aids is actually there's a lot of health system energy that goes into setting those up and then evaluating them and deciding what happens. So like I know, for example, that there are newborn clinics that are been set up, and maybe this is what this question is referring to. I think I've heard of that in the Nova Scotia, but maybe that's happening in BC too. I think in BC there were these urgent primary care centers set up, that some of which provide comprehensive care, but some of them do more kind of walk-in style episodic care. And I would say that I think we need to just really focus on having everybody have comprehensive care. And within that, I think we can prioritize, if we're investing there, setting up new teams, for example, who those teams prioritize and taking in. Absolutely newborns, people who are elderly or being discharged from hospital should be on that list of people we need to prioritize. But I don't think that we should be investing in Band-Aid solutions. I actually think that's going to cost us money, time, and resources that we don't have.
Thank you. And our next question, can you speak to how we break down hierarchy within interdisciplinary team-based care?
Yeah, that's a really good question. I think there are many answers to that question, many levels. There is, of course, the training part, and it's great to see that, there are places like UBC that are leading the way in terms of trying to train professionals together in a team-based way right from the start. And so, of course, we need the people who are coming out of our health professional schools to be able to know what their roles are. I would also argue in that light that, we have a 2-year residency in family medicine, but nursing and nurse practitioners or others, pharmacists, they don't necessarily and often don't have the opportunity to have primary care specific training. And I think that that's something that we need to work on across Canada, is for folks to be able to have primary care specific training. And I think that would actually help with this breakdown of hierarchy, because it would, ideally these curricula are made in conjunction with that professional group, but also with doctors, and then everybody has a sense of what it is that professional's role is and confidence in their training. And I think some of what happens right now is that people join a team, and what their role would be often depends on the doctor they're working with, for example, and their own personal confidence and skill set. There isn't really a standardized way in which people can be trained, and it's really up to the individual clinic and the individual. And I contrast that with the Netherlands, for example, where it was actually remarkable to me how uniform the role of the nurse was across multiple primary care clinics. And I think just the clarity of role and the confidence in the training in it of itself helps to break down traditional hierarchies, because people then are confident about their teammates and know what their role is. So I hope that's a part of the answer. It's not the full answer. There's, of course, other things we can do in a clinical setting, et cetera, but I think it's part of the answer. And maybe I can just have a request. Is it possible for me to just keep the questions of Slido on the screen there for a minute, just because, or put them in the chat, because I can't see them, unfortunately.
Yeah, if our AV team can make sure those are popped up, that's amazing. Thank you.
Thank you.
Yeah, and we probably have time for one or two more questions, so I'll just ask the next one, and this one is perhaps a bit controversial. Obviously, there's very different contexts across different provinces, but in what ways can the private sector or startups support primary care, and do you have any examples?
Yeah, so I think, I think we have to recognize actually that that we have private delivery of healthcare in Canada. Of course, doctors themselves, most of our offices are examples of private delivery. There's a difference, though, of course, between a single doctor or a group of doctors and a big corporation that has lots of shareholders and might be beholden to those or are beholden to those shareholders. But we do have private delivery in all of our jurisdictions across Canada. And I think, there is a role for that private delivery, the way we've set things up. We just have to ensure that there's like clear accountability and transparency around the delivery of care. So maybe I would say what we don't want is, I think, a situation where we fund a private sector company to, for example, provide, direct to consumer telemedicine care, and we don't know, anything about that care, like how much did it cost? How much is the government paying them to do this? Or how many visits are they doing? Who are they seeing? Is it equitable? Like, we don't want that. But what might be good, and I can actually, there's like some interesting examples, I think, in Saskatchewan and Newfoundland that I've heard of, and I don't know them in detail, but a company like Teladoc, I think, is an example where they're working with the government in Nova Scotia in a very integrated way, where their technology is being used to try and support people to access care in rural, remote regions where often there's a health human resource shortage. This is not direct to consumer care, I would say. So it's not that people are being asked to pay for this care or pay for supplemental care. It's actually it is really integrated, my understanding is, into the public system. People are, it's the technology that from the private sector that's being used, I think, and in conjunction, maybe they're also supporting staffing to like look at to have that access virtually. And then the government has said, okay, there's some in-person connections in certain locations. So if the person does need to be in person, then they would go to, X, Y, or Z location. In Saskatchewan, I think there's like a really interesting collaboration between a number of private sector companies, as well as a couple of Indigenous communities and government, again, to support the delivery of virtual care in rural and remote areas. So I think that those kinds of partnerships that, for example, these ones are, I think, Indigenous led in Saskatchewan. They're led by the people. There's transparency, accountability, and it's integrated with the public system in a way that also ensures transparency. I think those kinds of things can work. So I don't want to get too detailed about it because I don't actually know the details, but I think those are examples. And then I guess that kind of relates to the next question there, Teo, which is what were the observations unique to rural and remote communities? I mean, I think some of this really, there was quite a lot of discussion around this idea of virtual care being an opportunity to enhance access in rural and remote communities, but what that really meant. So, that also meant in those communities, often people didn't even have internet or not good bandwidth. And so it meant, they should have public spaces that they could go to in the community to be able to access the virtual care, for example, and the bandwidth needed to be better. But that if we were but that virtual care could save a lot of time and money and be more patient-centered in these contexts if done right. And virtual care was one piece, but they also talked about mobile care. So instead of people being forced to come down for care, can someone come up to the community? Can that be organized in a way that's more cost efficient? So those were some of the kinds of things that were brought up in relation to rural and remote communities. There were also some really creative ideas about retaining doctors in those communities. I think about in Nova Scotia, there were some specific examples of communities that use creative means to incentivize, first of all, host, I think, students to do their training there, and then try and continue to keep them there through different kind of incentives, and really community grassroots initiatives to do that. So I would say in Manitoba and in Nova Scotia in particular, if you're interested in rural remote care, there's quite a lot in those reports about that.
All right, I think we're at the end of our time. So I just wanted to say a huge thank you to Dr. Kiran. I think this was such a wonderful way to end our day. I know there's a lot of excitement right now for us at UBC Health, as well as others in the province, around opportunities for team-based care. So hopefully everyone was inspired by some of the ideas. And thank you, Tara. And I will pass it back to Naz for our closing.
All right, we're at the end of 2 amazing days. Clap for everyone in this room. That was great. Tara, thank you so much for that absolutely wonderful talk. That was great. As we wrap up, I just want to give a couple of reflections from the last 2 days. There's been a lot of energy, a lot of excitement, a lot of discussions happening, and some of the takeaways that I have from that is the need to embed equity, not only in outcomes, but also in our methods and our processes. The importance of relationships. We've talked about relationships starting from when Derek came and talked about the importance of grounding ourselves in the land, in the people, and really starting to build this relationship. And this reflection that I have, I'd like to share with the researchers in the group, because I think we often don't think about linking with the demographic that we're working with. We often have questions that we want to answer because we're very passionate and curious about questions, but we really need to find ways to include the demographic that we're working with, whether that are the patients or whether it's the parents of young children. We heard about somebody mentioning a 12-year-old as we talk about the effects of social media on youth, that we need to ask the youth what the solutions are. And often as academics, as somebody else pointed out, we tend to focus on the problem and the issue, and we get so wrapped up in that we don't get enough time to actually think about the solutions. So I think being creative and being open to make sure that we have meaningful engagement from the demographic that we're working with is really important. The importance of community knowledge and the lived experience in really shaping sustainable systems and influencing change in the way that Tara and her team have done, I think is really critical as well. So before I turn it over to Marie, I just want to thank all of you for spending time to come here and to share your ideas, your knowledge, and your energy. I think it's been great to see how excited people have gotten in the various rooms as we're discussing things across the 2 days. A special thank you to Elder Rose, Elder Kathy, Derek Thompson, also referred to as Chubut Wukwila. I finally got that right, thanks to him. All the speakers, all the panelists, the session leads, elders, Indigenous leaders, community members, and the partners who have made this event possible. We'd also like to thank the advisory committee who has really helped shape this program, and to our event team, the wonderful volunteers, the venue and the AV support, especially those behind the scenes and those behind the black curtain, to make sure that the event ran smoothly. So thank you to all of you, and I will turn it over to Marie in the Okanagan. Perfect, she's there. I'll step off and let you finish up, Marie.
Thank you, Naz. And I just want to echo your thanks to everyone also here on the ground here in the Okanagan, all of the team at UBC Health and all of the supporting people who made this event possible. So this is a research and action seminar, so we would like you to take some action. We're sending an invitation for you to share one key takeaway, one action, or one commitment through Slido. Please keep that QR code. Your contributions to this event will help inform our next steps, our future initiatives, and ongoing collaborations. So moving forward, UBC Health will gather all the insight over the past 2 days. We'll continue to support the connections, ideas, and momentum that we've generated here at this event. Look out for the recordings. Please look at YouTube. The recordings will be there. Share them with your networks as well. Also, we'll be putting up some highlights and also informing you all of future opportunities so that you can stay engaged with us. So we do encourage you to take a moment right now before you leave to share that one key moment for you. And if there's a conversation that you want to keep going or a partner that you'd like to work with, please let us know. There will be an opportunity for reflection and feedback, and we will be grateful for your input to help us learn and adapt for future programming and collaborative opportunities. So thank you, everyone, again, for sharing in this event. It's a Friday afternoon on a long weekend. So if you have traveled for the event, safe travels. We look forward to connecting with you soon, and please take some time and enjoy the long weekend. Thank you.